On February 6, 1998, at the age of 21, Auntie Duvniak was diagnosed with type 1 diabetes, a lifelong condition in which the pancreas produces too little insulin to regulate blood sugar levels properly. Determined to improve the quality of his life, the now 28-year-old Auntie continued to research and explore new methods of treatment for diabetes. What he discovered was something called an insulin pump.
Basically, once I was diagnosed with diabetes, I decided to do as much research as I can on the disease, understanding how to control it, how to prevent the complications that's going to arise in the future. I also noticed that there's a lot of new innovative technology that they're creating to control this disease. I realized that they had like a pump device which could feed me insulin continuously for forever, basically. So it's something I would be connected to 24 hours a day, 7 days a week, and it would just give me insulin. So I was interested in that device.
The first insulin pump was the size of a backpack and was developed by Dr. Arnold Kadish of Los Angeles in the 1960s. By the early 80s, fellow American Dean Kamen developed the first truly portable insulin pump. It quickly became known as the Big Blue Brick. Kamen would go on to invent and develop many more products, including the Segway human transporter. But it was the insulin pump that had Auntie's attention.
I was always interested in an insulin pump. So I got in touch with the company that produces the insulin pump, and they basically got me in touch with Dr. Perkins. So Dr. Perkins was willing to see me as a patient, and from there on, that's how I got to know Dr. Perkins, and that's how he became my doctor.
It was in December 2004 that endocrinologist Dr. Bruce Perkins first met Auntie.
Someone with type 1 diabetes being on insulin doesn't mean their sugars will always be normal. It actually requires a fair amount of work. So, for example, if Auntie, when he was on injection therapy, if instead of eating lunch, he wanted to go rollerblading, from the morning injection of his insulin, he'd have high levels of insulin in his blood, so he'd have to eat right on time. It's just very necessary to be more regimented with the time of meals on that kind of injection insulin therapy.
Diabetes research at the University of Toronto continues to this day under the direction of the Banting and Best Diabetes Center's Dr. Daniel Drucker.
As we are all aware, the best treatment for diabetes, whether this is type 1 diabetes or in fact in many cases type 2 diabetes, is insulin. And since the discovery of insulin at the Toronto General Hospital over 80 years ago, it has been difficult to find a better drug for the treatment of diabetes. Insulin use, however, is quite challenging. Patients with type 1 diabetes need to have insulin in their system at all times, and we know that too much insulin can increase the risk of having a low blood sugar, whereas not enough insulin will lead to inadequate control of the diabetes. So although insulin is a great drug and in fact life-sustaining for type 1 diabetes, it is not easy to use, and it would be wonderful if we could find better treatments that would make life easier for patients with diabetes. One of the very important advances in our ability to deliver insulin to patients appropriately has been the introduction of new devices such as insulin pumps that can in part mimic what our own body does in terms of insulin delivery.
I was basically interested in the pump. And he was telling me how it would improve my life, how it would give me a lot more flexibility and a lot more options. At that point, I decided that that was it. I wanted to have the pump instead of giving myself the 4 to 5 injections a day.
An insulin pump is a portable device that injects insulin continuously into the body in order to regulate the blood sugar levels of a diabetic. How does it work? Well, first the insulin is delivered through a tiny tube. At the end of that tube is a smaller, softer tube called a cannula. The cannula goes under the skin and is connected to the insulin pump. A small amount of insulin is given continuously. This is the basal rate, which is programmed to keep the blood glucose stable between meals and overnight. When food is eaten, the user programs the insulin pump to deliver a bolus dose, which is given to cover the expected rise in blood glucose that occurs after eating. The insulin pump is not automatic. The user still has to decide how much insulin will be given.
So the advantage of an insulin pump, when Auntie eats, he can take a bolus of insulin by pushing a button and a dose, and it'll give that spike. So now if it were lunchtime and he wanted to go rollerblading instead of eating lunch, he would be able to actually decrease the dose of his basal insulin, because it's going in minute per minute. He can control that and decrease that so that if he went rollerblading, he'd be less likely to have hypoglycemia.
Hypoglycemia, or insulin shock, occurs when a diabetic's blood sugar drops seriously below normal as a result of too much insulin, not enough food, or the person has exercised without extra food. Some symptoms may include moodiness, confusion, dizziness, blurred vision, and hunger. Taking a small amount of sugar, such as sweet juice or food with sugar, will usually help the person feel better within a few minutes. When left untreated, this condition can become severe and lead to unconsciousness.
First, people really need to understand diabetes well and insulin very well in order to be on a pump, because there are some potential dangers. They also need to be very involved in their diabetes care. They have to be willing to be measuring their blood sugar frequently. And all patients with type 1 diabetes really should be checking blood sugars at least 4 times a day, and before getting in a car to drive, or before going into a big meeting where if they were to have a low blood sugar it could have some consequence. So we need to make sure that he was doing these kinds of things. So when we start an insulin pump, first of all he needed to learn all the machinery of it and understand how the insulin in this works. First day that he was hooked up to the pump, we needed to start doing these things called basal assessments, the amount of insulin he needs throughout the day when he's not eating, which required doing these short fasts where he would skip meals and we would track his blood sugars. I need to tell you that a lot of people with type 1 diabetes, they've been taught over the years they need to have regimented meals, never miss a meal, never eat too little, never eat too much, and some people are prescribed snacks. So there's a big regimented behavior around the diet in diabetes. It's not a normal diet by any means, but the insulin pump permits normal eating habits, skipping meals, eating more sometimes, not eating meals right on time. So in this basal assessment we have people skip meals, and often it makes them very nervous because they're not used to that, and then it's a bit liberating to be able to do that. So this process actually took about 2 weeks, where he would skip certain meals and track his blood sugars. We'd review them, and we'd review them either by phone or by email, usually by email, so I could quickly see the numbers and give him advice without him always having to come back into the hospital. And we're actually we are developing a internet portal that would allow this to happen even more easily. In fact, a patient could put their pump in a cradle, it would download the information and be sent to me. I could review it and send it back to them. And I think this is the direction we need to go in this kind of therapy. There's no reason that people with diabetes should always be coming to hospitals for all of their care. They should be out there and enjoying their lives.